Hello, I'm Dr. Norman Lepor, the director of the National Heart Institute in Beverly Hills, California, clinical professor of medicine at the UCLA Geffen School of Medicine from 2010 to 2023, and attending cardiologist at the Smith Cedars-Sinai Heart Institute here in Los Angeles. I'm going to spend the next 30 minutes. We're going to be looking into the future, and what we're going to be looking at are what we would say are new targets and upcoming medication for dyslipidemia. These are my potential conflicts of interest. So as time has gone on, there's been a significant evolution in terms of our lipid-lowering therapies. We started back in the early 90s with statins. Then we had oral combination therapies with ezetimibe, icosapent ethyl, bempedoic acid, and even fibrates. Then we went to monoclonal antibodies, and these ended up being every 2 or every 4 week injections. So we were able to give potent medications on a much less frequent basis, which led to increased compliance. There are medicines that could be either weekly and monthly. Pelacarsen is one of the medications we're using for lipoprotein A in clinical trial. Then we have drugs like olpasiran and inclisiran, which are silencing RNAs, and they could be given every 3 to 6 months. And now we have even annual medicines that are in development. And it's possible that with interventions on DNA, genetic engineering, we may have medicines for severe diseases like homozygotes for hyperlipidemia for life. So when we look at all these different targets that we have available to lower lipids, it certainly provides a lot of opportunity for clinical research and pharmaceutical companies to come up with more effective and less frequently dispensed medications. And we're going to talk about some of these. We'll talk about the ones that target LDL. We'll talk about some new medicines that target triglyceride. And we'll even spend a little bit of time talking about lipoprotein A, which has been an area of great interest. So what we'll talk about here first, we're going to talk about impacts on LDL cholesterol. But just as a reminder, we're going to be spending a fair amount of time talking about these two targets, angiopoietin protein like 3, ApoC3. These are two compounds or two molecules that inhibit lipoprotein lipase, hepatic lipase, endothelial lipase, and they get in the way of by getting in the way of these lipoprotein lipases, they actually decrease the catabolism of triglyceride, predisposing to elevated levels of triglycerides. So we're going to talk about these two targets in terms of mode of actions in quite detail. And but still, we're going to first talk about some new and interesting approaches in terms of LDL interventions. Well, we all know about the PCSK9 inhibitors, and PCSK9 is a naturally occurring protein that gets in the way of LDL receptor recycling. Therefore, it reduces the ability of the LDL receptor to take on LDL cholesterol, internalize it in the hepatocyte, and thereupon lower LDL levels. So what we're going to talk about today, again, this will be the cholesterol ester transfer protein inhibitors, as well as angiopoietin protein like 3. But we're going to take a little trip and talk about a very interesting compound that affects the PCSK9 inhibitor that I think you'll be hearing a lot more about. So MK-0616 is a macrocyclic, it's an oral PCSK9 inhibitor. And because it's not an antibody, it could be given orally. If you gave an antibody, obviously you couldn't give it orally because it'd be broken down in the upper GI tract. But MK-0616 actually binds to the PCSK9 protein and inhibits the ability of that particular PCSK9 now to bind to the LDL receptor. So basically, it kind of paralyzes the PCSK9 protein. So whereupon the antibodies actually bind to the PCSK9 and reduce their availability by this binding. MK-0616 works by basically making the PCSK9 protein ineffective. And so this is the kind of results that we're seeing. This is a phase 2 trial that I was part of. Many of these molecules we're working with at the National Heart Institute in the Beverly Hills. And this particular phase 2B trial, and it was a fairly robust, diverse population of patients. About 50% were female, mean LDL cholesterol of 119. A lot of these patients had had suffered an ASCVD event. And what we're seeing in this phase 2B trial is the ability to lower cholesterol, LDL cholesterol, by 60%. So what we see here is actually this is an effective way that we can actually lower LDL and do it without an injection, as many patients really do not tolerate or would prefer not to have an injectable. This compound is now in phase 3 trial. Well, a very difficult population to take care of are the homozygotes for hyperlipidemia, HoFH. These patients present with LDLs of 5, 6, 7, 800, 1,000. These patients, the pure homozygote, does not have functional LDL receptors, so it does not have the ability to take in LDL cholesterol by binding to that LDL receptor. And they're a very difficult to treat population. They tend to have their cardiovascular events, such as heart attack and stroke, and even as early as their teenage years. So here's a very clever way of actually lowering LDL cholesterol in this population. Remember, we've talked about this angiopoietin-like 3 protein. And so what's really clever is we have VLDL actually made in the liver. It's secreted. And you have the lipoprotein lipase playing an important role in the degradation of VLDL into these VLDL remnants and further to LDL cholesterol. So by blocking the effect of angiopoietin protein like 3 with an antibody, we're actually able to enhance the catabolism of VLDL to the VLDL remnant. And rather than depending on the LDL, rather than depend on the LDL binding to the LDL receptor, you now have the ability to remove cholesterol in this VLDL remnant because it actually will bind to the remnant receptor. So this basically what this does, it increases the catabolism to the VLDL remnant and to IDL or intermediate density lipoprotein, allowing for its clearance and thereby lowering cholesterol levels. So what we see here, this particular antibody, which is available now, evinacumab, you can see that in this patient population, which for the most part does not have LDL receptors, you're able to reduce LDL cholesterol from baseline by just about 40 to 45, about 40, say 42 to 56%. And this is really an important innovation. Oftentimes these patients have to go for plasmapheresis. In fact, some still do. But oftentimes when you combine evinacumab with a statin, with a PCSK9 inhibitor, you can actually achieve reasonable LDL results. Now here's a method that is the CETP inhibitor story. It's actually kind of complicated. Cholesterol ester transfer protein is a plasma glycoprotein produced in the liver. It circulates in the blood bound to HDL. And what's important is it's involved in the transfer of cholesterol esters and triglyceride between lipoproteins. So what you have is it mediates the transfer of cholesterol esters from HDL, because HDL is really the lipoprotein that's packed with cholesterol ester. And it transfers the cholesterol ester from HDL to the ApoB containing particles such as VLDL, IDL, and LDL in exchange for triglyceride, which is heavily populates the VLDL molecule. So CETP, or cholesterol ester transfer protein, contributes to an atherogenic lipid phenotype in a variety of ways. It increases the cholesterol ester content and the atherogenicity of VLDL. And it also interacts with triglyceride lipases to generate the small, dense LDL, which we know is more atherogenic. And it also leads to a smaller HDL, which is more likely to be removed from the circulation by the kidneys. So the theory is by inhibition of the cholesterol ester transfer protein activity, we can reduce LDL levels and increase HDL levels. The LDL lowering effect, which arises from CETP inhibition, is anticipated to benefit patients with increased LDL cholesterol and increased cardiovascular risk. So this is just a diagram of how this works, as I've already talked about. You got VLDL secreted by the liver. So VLDL is really the lipoprotein, or the lipoprotein that's chock full of triglyceride. You have the HDL molecule, which is really filled with cholesterol ester. And so CTEP leads to this transfer of triglyceride from the triglyceride-rich lipoproteins, such as VLDL and VLDL remnants, to HDL cholesterol. HDL cholesterol transfers it to cholesterol esters to the triglyceride-rich lipoproteins, as well as transferring LDL cholesterol to the transferring cholesterol to the LDL molecule. So basically, it makes these molecules more atherogenic because it increases their content of LDL, of cholesterol ester. So cholesterol ester gets transferred to the triglyceride molecule, gets transferred to LDL in exchange for triglyceride being transferred from the triglyceride-rich lipoproteins to HDL, and as well as to LDL. So this is the Rose study, and I looked at a very interesting cholesterol ester transfer protein inhibitor, obicetrapib. And what we found is very effective reductions in LDL cholesterol, either by itself or when accompanied by ezetimibe. So you're seeing LDL reductions in the mid 40%, ApoB, which is those atherogenic molecules, by about 24%, total LDL particle by about 55%, reduction of the small dense LDL, that's the more atherogenic particle, by about 30%, and even a reduction of lipoprotein A by about 47%. So a lot of good things happen. Of course, when you mix it with ezetimibe, you add the LDL lowering power of ezetimibe to obicetrapib and get additional LDL reduction. So again, this is kind of the mode of action of obicetrapib in combination with ezetimibe. With ezetimibe, you're blocking this Niemann-Pick C1-like protein, which is involved with intestinal reabsorption of cholesterol. At the same time, you're having the effect we talked about with the transfer of triglyceride and cholesterol ester among the particles we talked about. So this is sort of the mode of action. So there's actually some genetic engineering that's occurring. There's actually therapies that are now in clinical trial, looking at actually DNA intervention. So Verve 101 was a CRISPR-based gene editing therapy in reducing LDL cholesterol. And what it basically does, it basically removes the PCSK9, the PCSK9 DNA. So basically, you're not making PCSK9. So overall, the findings showed that in 3 patients who received this Verve 101, basically leads to permanent activation of the PCSK9 gene, which we talked about. And they had reductions of LDL. Remember, this was a very difficult to treat population, heterozygote for familial hyperlipidemia. And we're able to achieve significant LDL reductions and rather profound reductions of actual PCSK9 levels itself. The PCSK9, the LDL change has actually been quite durable for up to 6 months, with follow-up ongoing. Unfortunately, the trial has been paused due to one particular patient developing thrombocytopenia and an increase in ALT. Obviously, we have to be careful with these DNA intervention studies, because once you've induced the change in DNA, you can imagine it's basically a one-way ticket, and we have to look at the potential side effects of such a treatment before we really move on into mainstream treatments. So what this study shows is the effects in terms of, compared to placebo, the reductions in terms of PCSK9 levels. And you can see PCSK9 levels were basically reduced, as we talked about, and you can talk about the associated LDL reduction. So we really are into genetic engineering in terms of LDL, but we're going to have to go slowly because, again, who knows the unintended consequences of DNA intervention. Let's talk about lipoprotein A. It seems to be a major focus right now of interest. So in terms of lipoprotein A, we know that lipoprotein A is associated with coronary artery disease, carotid artery disease, peripheral vascular disease, and of course, complications such as MI, stroke, and claudication. And what a lot of people don't know is that it's also associated with aortic stenosis. At the National Heart Institute, we're actually running trials in patients with mild to moderate aortic stenosis, and as well as evaluating patients with atherosclerotic coronary vascular disease to see the effect of lipoprotein A reduction with these very interesting compounds. And at this point, we're now in phase 3 studies. So what we know that these interventions that we're going to talk about reduce reduce lipoprotein A concentrations by 80 to 90+%. Now what we're trying to figure out is, can we connect the dots with this 80 to 90% reduction of lipoprotein A to actual event reduction? So there's basically 3 mechanisms of action for how we're able to achieve this LDL reduction. There's what we call the antisense oligonucleotides, which are single strands of RNA that get into the hepatocyte. And what they do is they lead to combinations with the intrinsic mRNA for lipoprotein A. They attach, ribonucleases come in and actually degrade the mRNA. So basically, you're degrading the mRNA that codes for lipoprotein A, and thereby you're blocking protein synthesis. Then we have what we call the silencing RNAs, and these are double strands of RNA that are directed to the hepatocyte, and they have a longer half-life in the liver because they bind to this what we call silencing complex. And what they do, again, what they have, and similar to the antisense oligonucleotides, is the fact that they chew up and degrade and targeted to degrade only the mRNA that is associated with coding for lipoprotein A. There's also a really cute molecule that is in early development, muvalapalin, and this binds actually to ApoA, so it binds to a component of the lipoprotein molecule. Basically, lipoprotein A is a combination of ApoA, which is this component here, with what is really, for the most part, an LDL molecule. So it's this binding of the ApoA to this LDL molecule that creates the lipoprotein A. And what this particular compound does, it actually binds to the ApoA so that it cannot bind to that LDL-like molecule, and thereby you don't end up with a finished LPA molecule. So in these mechanisms of action, you're actually affecting mRNA production, or actually not mRNA production, but you're affecting mRNA presence by breaking it down. This particular molecule, you're actually blocking the creation of the lipoprotein A by blocking the binding of ApoA to the LDL molecule. So these are the compounds that are currently in investigation. Pelacarsen, olpasiran are both in phase 3, as well as lepodisiran. Pelacarsen is an antisense oligonucleotide given once a month. Olpasiran is a silencing RNA, as well as lepodisiran. Olpasiran is given every 12 weeks. Lepodisiran seems to be able to be given in combination about every 6 months to a year. And one that's in phase 2 development, zerlasiran, is a silencing RNA that is probably going to be able to be given once a year. So this is really a composite of all the clinical trials in terms of looking at LPA, or lipoprotein A reduction. And you can see that basically very similar in terms of the extent of lipoprotein A reduction in that 80 to 90+% range. The big difference is really the durability of the effect, which means how frequent they have to be given. But I think this is a very exciting area of investigation. We're hopeful that this type of LPA reduction will lead to a reduction of events. The Mendelian studies are consistent with the fact that we'll see this result. And it seems that you really do have to get significant LPA reductions in that range of 70, 80+% in order to have a clinically full results. And again, we're investigating. Our site has been involved with investigating pelacarsen, olpasiran, and we're involved with the trials with lepodisiran. So I think this is going to be a very interesting area of discovery and knowledge enhancement to triglyceride-rich lipoproteins. And when we talk about the triglyceride-rich lipoproteins, the easy way we measure it is by triglyceride levels, although I must say that I'll show you that that's not a real, that's not a particularly um, um, appropriate way to measure the triglyceride-rich lipoproteins. But for the most part, we're talking about hypertriglyceridemia, the very severe hypertriglyceridemia with triglycerides in the, over 500 into the thousands. The concern there is related to pancreatitis and what we call the mixed dyslipidemia, those patients who have triglycerides between about 150 and 500. The issue related to triglyceride reduction is to reduce cardiovascular events. So the very high levels of triglyceride are usually associated with these chylomicronemia, these familial chylomicronemias. So where the idea is to prevent pancreatitis. In the mixed dyslipidemia, the goal is to modify ASCVD risk. And we already sort of went over this, but I'll kind of do it again. So VLDL is really the main, is really, in terms of lipoprotein, the main carrier of triglyceride from the exogenous pathway, the small intestine. The chylomicron is created and is released into the circulation, where lipoprotein lipase acts on the chylomicron, quickly converting it to the chylomicron remnants, where there's either the chylomicron remnant is either taken up by the liver, by the remnant receptor, or some of the free fatty acid from that remnant is utilized as energy sources for the adipocyte, muscle cells, and as mentioned, taken up with the liver. The endogenous pathway is when the VLDL is actually synthesized by the liver. Again, remember the VLDL molecule is a triglyceride-rich lipoprotein, and then through these endothelial lipases, lipoprotein lipase, it's actually converted into the remnants, eventually to LDL, where it's taken up by the liver and extrahepatic tissues. Now, what we're going to be talking about are these two molecules, ApoC3 and angiopoietin protein like 3. Both of these molecules basically hinder the ability of lipoprotein lipase to convert these triglyceride-rich molecules into LDL, where they are then taken up by the liver. So the goal, by blocking the effect of these two molecules, these two proteins, is to enhance triglyceride removal. And again, this just shows the VLDL life cycle, and we're going to be focusing in our clinical trials and the ability to affect the activity of angiopoietin protein like 3 and ApoC3, which inhibit the ability of endothelial lipase as well as lipoprotein lipase to actually convert the triglyceride-rich VLDL into the remnants as well as to LDL for their removal. Now, in terms of atherogenicity, the chylomicron molecule is not atherogenic. It's so big, it does not pass into the wall of the blood vessel. It basically bounces off. So that's why these very, very high triglyceride levels that are associated with chylomicronemia are not associated with atherogenesis. However, you do see, as you go along with lipolysis, as you go from the chylomicron remnant lipoprotein to IDL, intermediate density lipoprotein, VLDL, remnant protein, and VLDL. These are much more atherogenic molecules and are involved with plaque creation in the vessel wall. So we're not terribly worried about chylomicronemia. We are, because of the issues related to pancreatitis, but we're certainly much more concerned about these other molecules which carry triglyceride. So I think this is, a really important point, and hopefully probably one of the most important points of the presentation. So it's unlikely that triglycerides are actually the cause of atherogenesis, as triglycerides, unlike cholesterol, they are actually degraded by most mast cells and actually don't accumulate in the atherosclerotic plaque, as do the other molecules such as VLDL, IDL, and other remnants and LDL cholesterol. So therefore, high triglycerides should thus merely be viewed as a marker of high levels of cholesterol in the triglyceride-rich lipoproteins. A limitation of solely evaluating high triglycerides is that the cholesterol to triglyceride content in the triglyceride rich lipoproteins is quite variable. So a high triglyceride level may not actually give you much information about the atherogenicity of these triglyceride-rich lipoproteins like VLDL, chylomicron remnant, IDL, and LDL cholesterol. Therefore, clinically, it seems more appropriate to measure the cholesterol content of triglyceride-rich lipoproteins, we call TRLs, called remnant cholesterol. And actually, remnant cholesterol can actually be easily calculated by taking the total cholesterol minus the LDL cholesterol minus the HDL cholesterol, and that gives you the remnant cholesterol, which is probably something that's easy to do, and it should be done in your patients with elevated triglyceride levels to confirm the atherogenicity. So therefore, and we'll go into why this has implications with some of the other trials that have already been performed where triglyceride levels are reduced, but we're not seeing a reduction of atherosclerotic events. And maybe it's the wrong target. The target perhaps should not be triglyceride, but the remnant cholesterol. So we're going to look at the lipid-lowering effects of fenofibrate. We still use a lot of fenofibrate, probably overused. There really were two trials that showed a benefit of the fenofibrate, the Helsinki Heart Study and the VA HIT study, both with gemfibrozil, a drug we don't use much because of its safety issues and interactions with statins and other molecules. But what's interesting, in the Helsinki Heart Study, they looked at the different cholesterols to see what was associated with a reduction of cardiovascular events. And what was interesting is that triglyceride levels were not associated with cardiovascular event reduction. The cardiac benefits were actually associated with the increase in HDL and a decrease in LDL levels. So again, this tells us that maybe looking at targeting triglyceride on its own merit and treating with drugs that reduce triglycerides in general really may be the wrong approach. And because really the only compound, if you look at the fish oils, the only fish oil, the only omega oil that really seemed to have an effect on reducing cardiovascular events was icosapentaenoic acid. And as in the REDUCE-IT trial, it actually reduced cardiovascular events by 25% on top of statins. Now, what was very interesting about this study, this was patients who had either diabetes or had atherosclerotic coronary vascular disease, is that the reduction of cardiovascular events was not related to triglyceride levels. So there was something independent of triglyceride, which led to the benefit that was accrued. And if you look at the very large trials looking at combinations of EPA and DHA, where you had quite potent reductions of triglyceride levels, we did not see a reduction of cardiovascular events. So therefore, it's not just the triglyceride level reduction that is leading to a cardiovascular event. It may be, as we talked about, the reduction of those remnant molecules that contain higher levels of cholesterol ester. So there is a compound that is quite potent at lowering lipids. It's the angiopoietin-like 3 inhibitor. We talked about that already in terms of LDL reduction, but it's also quite potent at triglyceride reduction. It reduces triglycerides in a particularly potent way. Also has an effect in terms of reducing LDL cholesterol. So here we may have a drug that is effective in terms, perhaps, in reducing cardiovascular events by virtue of more the effect of its LDL lowering effect and not related to the lowering of triglyceride, which we see from previous studies. Triglyceride reduction in itself did not seem to be related to to event reduction. And what we're going to talk about as we go further, so there are two other angiopoietin-like 3 inhibitors that are in clinical trial. One is an antisense oligonucleotide, one is a silencing RNA. And what we see here is the ability to lower triglyceride, also the ability to lower LDL cholesterol. So these may be compounds that may be useful to lower triglyceride in those patients that we say have this mixed dyslipidemia. And we also have the effect of lowering triglyceride levels with that ApoC3 inhibition. So remember, ApoC3 inhibition leads to a more active lipoprotein lipase. And these three molecules, two of which are antisense oligonucleotides and a silencing mRNA, we see rather potent reductions of triglyceride levels. Unfortunately, what we see in some of these cases are actually increases in LDL cholesterol. So we're going to see in the cardiovascular event reductions, because these are very potent reducers of triglyceride, these may be great drugs for patients with the more severe hypertriglyceridemia. And the angiopoietin-like 3 inhibitors, perhaps, this is only a theory, they may be better for those patients with mixed dyslipidemias, because the ApoC3 inhibitors can show an increase in LDL cholesterol in these chylomicron inherited disorders with really modest decreases in LDL. Angiopoietin-like 3 molecules have a more potent decrease in LDL cholesterol. So again, we'll see what the cardiovascular event trials show. They both perhaps seem to have places to treat patients with triglyceride disorders, and we'll see how it plays out in the CV outcome trial. So let's dig into the data a bit. We'll look at olezarsen, which is a GalNAc conjugated antisense oligonucleotide against ApoC3. Here you see the data. You can see very potent reductions of triglycerides in the 50% range, VLDL cholesterol by about nearly 50%, similar reductions in those atherogenic remnant particles, 18% reduction of ApoB, very minimal reductions of LDL cholesterol in that kind of 7 to 9% range, but at least we're not seeing increases. And we could see the durability of the effect of this drug out to 12 months. So this is olezarsen in patients with moderate to severe hypertriglyceridemia. The drug seemed to be safe in these trials. You did see some modest increases in liver function test, the AST and ALT, but these reductions were generally quite small. Plozasiran is a conjugated hepatocyte-directed silencing RNA. It's actually administered quarterly, so we're talking about a drug given every 3 months. And we'll look at some of the data. And what we can see here, excuse me, what we can see here is rather potent reductions of triglyceride levels. And so this may also be a very meaningful compound to treat patients with hypertriglyceridemia, reductions of remnant cholesterols in the 60% range. So it does have some very positive effects, and we'll see how things go in the CV outcome trials in terms of their ability to reduce cardiovascular events, very potent reductions of triglyceride. So we're seeing, at least from a lipid point of view, very favorable enhancements on lipoproteins. This is the MUIR-3 trial. This is looking at patients with the mixed dyslipidemia. And again, what we're seeing is potent reductions of triglyceride, remnant cholesterols. Here we see rather significant increases in HDL cholesterol, reductions of ApoB, pretty much LDL neutral, and reductions of non-HDL cholesterol. So here again, we have a molecule which tends to have very positive effects on the lipoproteins, and hopefully we'll see what the CV outcome trials show. And this is, again, looking at the safety in the MUIR-3 trial. And what we can see here is, for the most part, again, these are pretty small trials. We really did not see any major adverse event signal. But again, we're now going to enter phase 3 trials with these compounds where we'll learn more about the triglyceride theory of CV event reduction, as well as the impact of these very important drugs. We're now in a phase 2 trial looking at severe hypertriglyceridemia. We talked about evinacumab, which is the antibody directed against angiopoietin protein like 3. And this is looking at patients with very high triglyceride levels. These are the chylomicronemias. And we actually found very potent triglyceride reductions, as well as remnant cholesterol in this particular patient population as well. And this is looking at another compound. This is looking at a silencing RNA in mixed dyslipidemia, targeting now angiopoietin protein like 3. And again, very favorable reductions of triglyceride, remnant cholesterol, ApoB, basically LDL neutral. In this particular compound, we did see a reduction of HDL levels. So you can see these different compounds have differing effects on lipid metabolism. So it's really going to be up to the larger CV outcome trials to really provide us direction in terms of which of these agents are going to prove to be most useful, both in terms of reducing triglycerides in the severe hypertriglyceridemic patient, as well as in reducing cardiovascular events in the mixed dyslipidemia patient. So in summary, these are new targets for lipid modification. They include non-statin LDL reduction. We talked about the effect on the oral PCSK9 inhibitor. We talked about the cholesterol ester transfer protein. We talked about the effects, the very congested area of discovery with the triglyceride-rich lipoproteins, where we hope to learn a lot about how do we manipulate triglyceride in order to reduce cardiovascular events, and the very exciting area regarding lipoprotein A. And it's really going to be ongoing clinical trials that will test some very important questions, including the effects of these agents and innovations on cardiovascular risk. Thank you very much.